therapeutical measures such as, for instance, hormones to stop their puberty development, and in order to avoid certain developments that are contrary to the development of the kid. So thank you very much for listening, because it's going to be a difficult presentation. It is very difficult to find experts of his level and of the level of Dr. Cretella as well, who are such specialists in their fields, because they really know what they're talking about. So thank you very much, Dr. Hruz.
Thank you very much. I want to extend my thanks to all of you for being here, and all of those that are viewing online as well. In entering into this dialogue on this very important topic, what I hope to share with you this afternoon is delving in and really extending and deepening the conversation that we've already had throughout the day today, and really specifically talk about some of the medical treatments that are being proposed in treating individuals that present with a gender identity that is not in alignment with their biological sex. I should state as a disclaimer, even though I have the privilege of working at a very prestigious academic institution where I carry on my basic research, care for patients, and are involved with education, I'm not speaking on behalf of my university, but I'm speaking to all of you with my experience in being able to evaluate scientific questions and being able to address areas of medicine. And I want you to have some background and knowledge as we discuss this very important topic, so that we can enter into the dialogue recognizing where there are not just disagreements, but fundamental defects in what we're proposing as the state-of-the-art treatment. And for those that are engaged in this discussion, to recognize from a scientific basis the standing that one has, and at least questioning the treatment that's being provided. Now, we've already heard a lot today about this widening cultural divide, about this understanding of who the human person is as male or female. And we know that this conversation is going on the internet, it's happening in courtrooms, it's happening in legislatures. We can talk about theology and philosophy, but we're going to talk about medicine and science in my portion of the talk here. And I want to begin really sincerely engaging in a conversation with those that may be listening in, that may have the impression that we don't care. We need to say up front that many, many individuals that are presenting with a gender identity that's not in accord with their biological sex are truly suffering. And we know this. We know that these individuals are at a markedly high incidence of suicide. By the scientific data that's available, nearly half of all individuals that are transgendered will have contemplated suicide. And unfortunately, about a third will have acted upon that thought. We know that transgendered individuals have higher incidences of depression and anxiety, substance abuse. Many of them have been exposed to various forms of violence, whether sexual or physical. This is a reality. This is the statistics that are out there. Now, as we're discussing this, we need to acknowledge, and it's been brought up earlier, that a component of this difficulty does relate to the way that our society deals with these individuals that have this transgendered identity. The question is that the whole story? Is there more to the story here? And why is it important for us to get an answer to that question? As a physician, we need to know what the cause is of this condition to be able to effectively propose effective treatments. And what we're going to find in our discussion here is that much of the information that is critical to proposing this treatment paradigm is sadly lacking. Another very important component of the urgency of what we're talking about this afternoon is that this whole phenomenon is not just coming on the social scene and being discussed more frequently, but we're finding that more and more individuals are presenting for these medical treatments that we're going to talk about. Now, we can listen to some of the advocates who will propose as a hypothesis, and I want to be very clear, by hypothesis, in science we talk about this as an educated guess, that we actually look for evidence to be able to support it, and if the evidence is not there, we think of other hypotheses that may be accounting for what's going on. The hypothesis as to why these individuals, and this is some data shown on the slide of from one particular center, that almost 2,000% increase in just a few years of people presenting for this care. It may be argued that these individuals have always had this condition and they've been in the background, and because these centers are becoming widely available in the United States and throughout the world, that they are now coming forward. As an alternate hypothesis, we can ask the question, is what is being presented about this condition influencing the natural history and trajectory of what we're seeing? Are more and more individuals coming forward because they're looking at the problems that they're experiencing in their life and looking at this proposal that it's because of a transgendered identity and are seeking care as a result of that? We can at least ask that question and then try to design studies that might answer that question. Now, I'm very glad that you've already been introduced, if you've not seen this before, the gingerbread person. This is actually one of the earlier versions, version 1, which actually presents these different entities of gender expression and biological sex. And the reason I show this version of this is because it shows this idea that there's a continuum, not just of gender, but of sex. And this is an area that I think that I can speak to in my experience of dealing with the unfortunate situation of children that are born with variants of the normal anatomy that one would expect for male or female. Children that have disorders of sexual development. Again, the term intersex is not routinely used. We like to say disorders of sexual development because of the negative feelings that people get by being labeled as having a disorder. Many people want to just call it a difference. But again, we need to look at what we mean by that difference. So as we get to the next slide, I think what's really important as we think about this, again, from a biological standpoint, I'm going to reiterate what you've already heard previously, is that this idea of sexuality or male or femaleness is intrinsically related to the process of reproduction. And it's not true for just humans. It's also true for animals throughout the animal kingdom. And the reason why we have this method of reproduction has a very important biological component as far as allowing genetic diversity. I'm having difficulty advancing the slides. I don't know if we could. Okay. So as we. But we can keep talking. Okay, there we go. So again, to reiterate, the purpose of sex is reproduction, and in the process of that, what we're looking at is really what are the players in that reproductive process. And really, when we think about reproduction, there really are only two gonads. Okay, there are testes for males and ovaries for females, and the definition of the role that one plays in that is related to that role in reproduction. The male donating the sperm, the female donating the egg, the reproduction of the female happening within her body, the male contributing to that reproduction outside the body. And again, when we look at this, when we think about these conditions of disorders of sexual development, the important point, there's actually two very important points there. One, there is no third gonad. There really are only two gonads that we are aware of that actually contribute to this process of reproduction. So I think we need to know that as well. The other very important point is the vast majority, nearly all of the individuals that we're talking about with transgendered identity do not have a disorder of sexual development. They have perfectly normally formed primary and secondary sexual organs. So they have normal uterus, they have normal penis, they have a normal ovary and testis. So we're not talking about disorders of sexual development when we're talking about transgender. But I think it is helpful from a biological standpoint if we do separate out this concept of sex and gender. And we can look at gender as an expression or how we behave as male or female. But if we take those gender and sex and separate them, it does not mean that they're not related. From a biological standpoint, gender, or the roles that we have in our behavior, are related to the process of that reproduction, the behaviors that we engage in, and actually the roles that we take in the rearing of the children that come out of that sexual act of reproduction. Now, let me spend just a few minutes talking about this question of cause. And I mentioned it earlier. I think it's critical for us to understand why people are developing this transgender identity, and really ask and question some of what has been put forward about this is something that somebody is born with, it's immutable and present for life. Now, again, we heard from Glenn at the last talk, the inconsistencies with some of those arguments. But let's just put this forward with the incomplete information that we have, and say that we don't know what the cause is. I think both advocates and those that have concern with the current treatment paradigm will agree with that. But we do have evidence that there are probably genetic and environmental influences upon this condition. And one of the pieces of evidence I think that are really telling in this is some very nice studies done in identical twins. And when you look at these studies with identical twins that have exactly the same genetic information, and they were actually raised in the same uterine environment, if it was 100% genetically determined that this is who somebody is, you would expect that if one individual has transgender identity, that the twin would have that same condition. And actually what we found is it's much lower than that. It's about a third, depending on the study that we look at. It's not 100%. And it also doesn't say that there is a transgender gene. Because when we talk about genetic contributions, we can think about many other hypotheses as to why that actually influences the trajectory that they assume. For example, we may consider that it may be a person's ability to respond to stress. They have different coping mechanisms, and that may be a genetic influence. We know that from many other conditions, alcoholism, compulsive gambling. It doesn't define who the person is. The fact that we know that some of these conditions can be inherited and influenced within families. The best we can say, it's very likely to be multifactorial, and it's very likely that any one individual has different contributing factors. And that is critically important when we think about a treatment paradigm, because treatment approaches cannot be a one-size-fits-all. We need to be able to tailor the treatment to the individual, what the causes are, and be able to understand more deeply what those causes are to be able to propose an effective treatment. Now, let me just walk you through how the treatment that we're currently offering to transgendered individuals that experience gender dysphoria, again, not just a transgender identity, but have discomfort with that condition, and seek to have alleviation of that discomfort. Now, the traditional approach that had been going on for decades was to recognize that this is an objective mental disorder. And actually, when we look at the psychiatric manual that defines psychiatric conditions, in the last edition, the previous one to the current, it was defined as gender identity disorder. Now, recognizing, or at least approaching this problem from that standpoint, the attempt at treatment is geared toward either just expectant waiting or being able to counsel that person on that psychological difficulty that that person is experiencing. Now, I say expectant waiting, and let me say this, you heard a little bit about this earlier with Dr. Gratella's talk. In children, the estimates will vary, and I will say that the studies are not perfect, but we have nearly a dozen studies done over several decades that all consistently show the vast majority of individuals as children that present with transgendered identity, if you merely leave them alone, will re-identify their identity with their sex. So it seems like a pretty good treatment strategy if the natural outcome is for most of these individuals to realign their gender with their sex, that perhaps we should allow that process to go forward. And again, the estimates, probably the best estimates are about 80 to 85%. They range anywhere from 50 to 98%. Now, we want to switch to what the current paradigm is, because when that psychiatric manual was revised a few years ago, the paradigm actually was completely changed. So now we've kind of turned it on its head, and now we assert that gender variation is normal, and that the focus is on alleviating the gender dysphoria, and we're not addressing this as a mental disorder. We're looking at this as a physical disorder, meaning that the body is not conforming with the mind, and the mind is what is dictating what reality is. And as a result of that, that's where these hormone treatments have come into play. So we're going to talk in more detail about each of the different components of this therapy. But from an endocrinologist, I'm a hormone doctor, an endocrinologist, the hormone treatments begin when puberty starts, okay? So the normal process of pubertal development, and at the time that this occurs, the first medical intervention is going to be to suppress that puberty. So take a normal process, say that it's at normal, treat it as a disease, and be able to stop that. Now, we can say a lot about the process of puberty, which fits as one component of a much broader question of adolescence, the changes that occur as an individual goes from childhood to adulthood. And we know anybody that's gone through puberty, and it's everybody in this room, that adolescence is an inherently stressful time of life. There are many different developmental milestones that people need to go through. So it's not unexpected that if you interfere with puberty, that discomfort for a time can actually be alleviated. The next step in the treatment is if that desire continues, that the ages were set at 16 years, that you could begin cross-sex hormone treatment. What I mean by that is if you're a male who wants to be appearing like a female, you start taking estrogen, and if you are a female that wants to appear as a male, you'll start taking testosterone. And then when you reach the age of 18, generally, then you can be offered surgical intervention. Now, as the process of this paradigm has evolved, these ages have gotten younger and younger and younger. So the argument is, why wait, and let's just do this at a very early stage. Now, one of the challenges that one has, if one wants to raise some of these scientific questions about whether this is the best way to move forward, is that this treatment paradigm that is now being put forward is codified in a number of professional societies as far as the guidelines that practitioners or physicians should follow. Now, if we look at that transition from the old paradigm to the new paradigm, one would expect that there was a landmark study that had been done, or a series of studies that had been done, to show that we have all of this evidence in place that this is what we need to do. And if you listen and you read about the story of how this change occurred, you will find that this was based on ideological grounds with no data or very, very little data, and more hypotheses and a desire to be able, and a lot of influences. Now, I want to at least have you aware of what we mean by clinical practice guidelines and why it's critically important to be able to question this. Now, in any clinical guidelines, there's benefits and there are drawbacks to clinical guidelines. They help to synthesize a large amount of information. They help to standardize care. But guidelines are only as good as the evidence that you have to back them up. And there is historically a long precedent of guidelines that were put forward that when new scientific evidence emerged, we found that we were actually wrong. And I'm talking major changes in the way that we approach treatment. One that many people are aware of is giving hormone therapy to postmenopausal women. Another example would be giving the steroids in people that have had a traumatic spinal cord injury. And really, we need to know what is the data that's supporting this. Now, fortunately, in most clinical guidelines, they actually rigorously look at the scientific evidence, and they present that within the guideline. Now, they don't do this with the WPATH guidelines to the same degree, but in my professional society, the Endocrine Society, they fortunately have spelled out what the evidence is. Now, looking at this, they're graded. It's called the grading system. It goes from very low information to high level of confidence in the information. And by criteria, low or very low information tells me that we have really very little to go on, and it's very likely as more information is presented that we're going to see a change in the recommendation. It may be shocking to many that haven't read the guidelines that nearly every single one of the recommendations made in the treatment guidelines is based on low or very low scientific information. The only information that reaches to the level of moderate evidence is actually for complications of therapy, things that are bad that occur as a result of that. Okay, so anybody that wants to challenge that, there really is very little evidence to support the guidelines. And I've had the opportunity to talk to many of the people that are providing this care, and they all acknowledge this. This is well known, this is incontroversial, and there's a need to gather more information. What are the problems with the research studies? First off, there's a very small number of studies. Many of them have very small sample sizes. For example, studies done on 1 or 2 dozen individuals. I said earlier that it's likely multifactorial, meaning that there are many different causes in any one individual. I don't know how many people here would be comfortable changing the way that you try to prevent cardiovascular or heart disease based on a study done on a dozen patients. I think we would want more evidence than that. Many of them are convenience samples. For example, the studies are to have an internet survey that people can come and fill out. Again, inherently biased. Most of them do not have control groups. And that's critically important to know that our intervention is actually making the difference. And there are many other problems with the research that is going on. Now, we have to look at this information in the context of what we have, and then be able to think about what we can do moving forward. Now, we want to, in a minute here, I just want to be able, if I can get the slides to go forward again, to ask some of the questions about each of the interventions. I'm going to go very quickly in the area of social affirmation. This is the idea that we need to encourage individuals in their transgender identity from a very early age. And now the recommendations are as early as 3 years of age in many situations. Recognize that, for example, questions like bathroom use and all of these other things, there are no controlled trials that have been done to show that this is actually a prudent approach to move forward. Again, we're talking mostly about hormones, but it's able to, and actually, if you look at the guidelines that were first put forward, they actually cautioned against, in the guidelines themselves, in the edition that came out in 2009, against social affirmation because of this data that I presented earlier about the high rates of desistance or going back with a gender identity in agreement with your sex. Now, the latest version actually has really softened that recommendation. Now, with that, I want to then proceed on to a discussion about pubertal blockade. This is that first step of intervention. It's important to know how these medicines work. They actually work at the level of the brain to shut down the normal functioning of the gonad, the testicle or the ovary. Now, they're claimed to be fully reversible and entirely safe. And the rationale for using them, again, as I said, is to alleviate the dysphoria that is going on. I can use an analogy here. If my students are going to have an exam next week, and then I suddenly say they're not going to have the exam, their discomfort with that immediately goes down. We can say that the same thing can happen to alleviate dysphoria. But to say that it's safe and reversible, and as Dr. Cortella mentioned this morning, there are no studies that are specifically done in transgendered individuals under the proper conditions for scientific study to say that it's safe. They are not approved in the United States by our Food and Drug Administration for that use. They're used for other indications. So to make the claim that they're safe without data is not accurate. To say that it's fully reversible when you're actually interfering with the normal developmental process. Okay, just think about this, okay? We're talking about changing normal pubertal development, and it's true to the extent that if we give pubertal blockers that shut down the whole process, and we stop giving the medicine 4, 5, 6 years later, the body will readjust and start those signals again. In that sense, it's reversible. However, we have halted a normal developmental process, and if we go back 5, 6 years later, we cannot say that we can go back in time, and we've influenced that all of the other things that happen at that age in adolescence. So it's inaccurate scientifically, logically, to say that this is reversible, okay? And then, the rationale is that this is going to have a lasting impact on these individuals. Again, many of these things we talked about or heard about. We talk about the low bone density. The puberty is a time when children develop their maximal bone density. By halting this process, there's good evidence that they're at higher risk of having osteoporosis later in life. Dr. Cotella and others have already mentioned that when we begin pubertal blockade and follow that up with cross-sex hormones, we're really inducing likely a permanent sterility in these individuals. And then the question is, does this have any influence on the trajectory? I mentioned earlier in the epidemiology, or the number of individuals coming forward, that this intervention may actually be influencing the number of people that are going on to request cross-hormones treatment when they're started on pubertal blockers. And I think that we don't have a full story here. There are many individuals that once they go through treatment will recognize that this did not fix their problem and will seek to reverse that. But in the published studies that have been done, rather than having 80 to 85% have a realignment of their gender identity with their sex, in one of the studies that was done, all of the patients, 100% of them that got puberty blockers, went on to get cross-hormone therapy. Quite a discrepancy in the numbers there, and it leads to a hypothesis that you might be influencing that. Again, short-term gains in the very short run, if you look at the data, and much of this data that is being coming forward in an uncontrolled manner in children, it's been long-standing in the adult literature that when you go ahead and give cross-hormone therapy, that there's an immediate benefit with the dysphoria, but it doesn't last. The data that we have long-term, and we're looking at some large studies, and I can't be a scientist and not show you actual data, so I'm showing you two pieces of data. I could show you a lot more. One is looking at, from a study done in Sweden, that actually shows the cause of death in people that have gone on to get this cross-hormone therapy with or without surgical treatment. We're talking 20, 30 years into the future. And Dr. Cortella already shared with you the alarming statistic that there's a 19-fold increase rate of completed suicide in people that have gone through this therapy. In that study, there's no control group, so we can't say what it would have been without the therapy, but what we can say with confidence is it did not fix the problem. Unless you think that this is an isolated study that had some sort of bias, I'm showing you data from something called a meta-analysis where they've taken over 40 studies, again, each of them with different design, some of them better than others. Consistently, this data shows the same figure. 50% of these individuals have contemplated suicide. And if you look at the data on the far right there, comparing what the rate of suicide attempt or ideation was before treatment and after, you actually see that it goes up. Okay, so we have to question this claim that what this treatment paradigm is doing is having benefit for these individuals. Now, I'd like to finish with just a few very hopefully clear slides talking about the area of medical ethics. And I think that this is a domain that a physician and a scientist needs to be aware of and address head-on. And I think everybody that's listening to this and is in the room here should know that these concerns are more than theoretical, okay? What is going on, and it's already been mentioned earlier, when you do a treatment, when you don't have the data showing that it actually helps, okay, and you're trying to gather the data as time goes on, that what you're actually doing is experimentation. We have very safeguards in any form of experimentation in human beings. The bar is much higher when we're doing experimentation with children. What's happening, though, is this treatment is being offered to individuals without telling them that it's experimental. They're not getting their consent. But when you ask the people providing the treatment, what long-term data do you have? These are the people actually giving these hormones. What evidence do you have long-term that this is of benefit? They will tell you, honestly, we have no evidence. So it fails on the standard of ethics and experimentation on children. There's an entity called, or ethical principle of beneficence, doing what's good for a patient. Since we have data showing, questioning whether this is a beneficial treatment and showing at least evidence that there's some bad things that may happen, we can't claim that this meets the criteria of beneficence of being able to do this treatment. What we really need is properly designed clinical trials that include controls. And by controls, I mean it's not leaving somebody to their own. It's actually designing alternate hypotheses, alternate interventions, and we can have a long discussion about what those interventions might be. But to say that we can move forward from an ethical standpoint with the evidence we have is a violation of a basic ethical principle. The next one is autonomy. And again, we touched upon this earlier when we were talking about development in pediatrics. We are proposing something to adolescents that we would not allow them to do in any other way whatsoever. We know that adolescents act on impulse. They react to social cues. They're much more likely to get into accidents, involved in all sorts of dangerous and risky behavior. And we know this by the laws that we have of when they can drive a car, when they can drink alcohol, all these other things. And so that when we think about autonomy, you have to question whether these children that are given, and many times against their parents' best judgment, to be able to go ahead with this therapy, fails in the area of autonomy, and there's much more dialogue that we need to have to be able to establish this ethical principle in this particular domain. The last ethical criteria is non-maleficence, and what that means is don't do things that are bad. And this is a tenet of medicine. Above all, do no harm. There are many diseases that we experience in the medical profession where we do not have an adequate therapy. As physicians, we are not to do something that is harmful, and I've already showed you some hints of data that suggest that this may indeed be harmful. We need to discuss this more in the area to fulfill that criteria of non-maleficence. So I'm going to end with a partial answer to the question that comes up repeatedly. Well, what do we do? These children are here. They are suffering. They deserve our compassion. They deserve our best efforts to being able to treat this as a medical profession, but as a society as a whole. So we need to have compassion for these individuals. We need to enter into their suffering. I think that to say that somebody does not have dysphoria is like telling somebody that has pain that they don't have pain. That is what they are experiencing. We need to walk with them, meet them where they are, and walk with them on that journey. And at the same time, we need to be able to maintain the biological reality of what's present and what's going on. We can certainly work with them to eliminate injustice, unfair prejudice and discrimination and bullying, as we talked about. We can provide psychological counseling and support, even if we don't know what the full cause is, even if we don't have an ability to change that trajectory in some individuals. We do this in many, many other areas of medicine, where people have psychological difficulties, where we walk with them, we provide support, we help them to be able to cope with the stress that they're dealing with. This is certainly an area where we need a tremendous amount of additional scientific information. We don't benefit anyone if we're setting up separate camps and being able to jettison all attempts toward dialogue. We have a shared goal. Those that are advocates of the current treatment paradigm and those that have serious concerns based on scientific and ethical grounds can come together and say, we desire to help these individuals and alleviate their suffering. We can begin that conversation there and actually begin to work on developing the scientific information that's necessary to be able to get the proper treatment moving forward. Again, I want to thank all of you for being here. I want to thank you for your attention, and certainly be happy to take any questions. Thank you. Thank you very much.
Yo no necesito. Thank you so much, Dr. Hruz. Muchas gracias al doctor por aclararnos. Tengo muchas preguntas.
Thank you very much, Dr. Hruz, for clarifying so many aspects. I thought that I wasn't going to come up with so many questions being such a medical talk, but I have received many questions that have to do with management, with therapeutical management for this type of individuals and for these children too. First, I would like to ask the doctor, has the existence of a gene linked to transsexuality been proven?
Whether we know what the genetics are, the answer is no. We have no idea what the answer is. There is a study that's going on, sponsored by the National Institute of Health, to sequence the entire genomes of individuals with transgender. It's questionable whether they're going to find the answer. As I mentioned in my talk, what they may find are heritable traits. They may not, if it's depending on how many genes are actually contributing to this. To put forward that there's a, quote, transgender gene or something that dictates who they are in their transgender identity is highly questionable, and we have really no answer to what is going on at a genetic level. But again, we have to be very careful. We have many other experiences when we think about other conditions where we've sought in a complex area such as transgendered identity of uncovering. The evidence actually suggests that we are not going to find a single gene that is contributing to this. We may find genetic clues that may predispose somebody to moving down that trajectory. And even if we do find that, then the questions will only begin. Are there, with that knowledge in hand, right now there's no biological test that you can look at anybody and predict from a biological, genetic, hormonal measure what their gender identity is. There's not a test that can be done. So we need a lot more work to be able to gather that answer.
¿Diría usted entonces que
Would you then say that environmental factors play a bigger role on children or on people who have gender identity disorders?
In the discussion of causes, we absolutely have to look at environmental influences. And I mentioned just one piece of information, that the twin studies, but there are others as well. And there's certainly a need to dig deeper and understand what they are. There are certainly some clues about what is going on as far as the number of individuals that have experienced. Again, we look at some of the social stress that they're experiencing, the incidence of events in their life, differences in family dynamics, exposure to different forms of abuse, different ways that they've responded to different events in their life. And really what we see is that there could be two individuals that were experiencing the exact same adverse event, and they may have very different responses to that event. So it is an area in need of a significant amount of additional research. But I think the evidence that currently is available speaks very strongly that it is a major influence, if not the predominant influence of this condition. And again, much more needs to be done to understand this.
la anorexia nerviosa?
Anorexia nervosa is a disorder that may perhaps resemble the disorder that we are tackling here, the misalignment with biological gender, or biological sex. Most girls that have anorexia nervosa have a distorted image of themselves. They do not identify with their body image because they may be malnourished and they still see themselves as fat in the reflection on the mirror. But the way these girls are therapeutically managed, the way these girls are treated is radically different to the management that we are considering for these children. These girls see themselves as fat on the mirror, but physically they're very thin, even malnourished. And sometimes we see children or pre-adolescents or teenagers that have a biological sex, a specific biological sex, but they perceive themselves as something radically opposed to what they see on the mirror. And therapeutical management is completely different for them. Everybody can accept that for a girl that suffers anorexia, when she says, I think I'm fat, even though she's thin, nobody tells them, okay, go ahead and lose weight. And what they try to do is to give them food and try to get them to gain weight. So could there be similarities amongst these two distortions?
Question of anorexia nervosa and comparing that to gender dysphoria, there are similarities and there are differences. Objectively, what is occurring as far as the discrepancy of what one thinks and what the biology shows is the same, as far as there is a discrepancy there. I have to accept that people that are entering into this treatment paradigm are well-intentioned. And the difference is that we know very well, and it's very apparent in anorexia, the immediate effects of malnutrition that will lead to death if you do not intervene. In gender dysphoria, it's a little bit more difficult for one to see that. One, because the studies haven't been done, but two, because we have this short-term alleviation of dysphoria, and we haven't looked out far enough to see the problems that are occurring, even though the clues are there, and we discussed that just a minute ago. And I think that the difference is in the timing of when we see these adverse effects, and that it may not be apparent to everybody that's engaging in this treatment approach can see that similarity. But clearly, there is the mind says one thing, the body says another thing. Objectively, there's a discrepancy there, and our approaches are entirely different. And I think that it is appropriate to question the treatment paradigm in light of anorexia nervosa and other conditions like body integrity disorder, identity integrity disorder, and these other conditions. But trying to fairly understand how people can buy into that treatment approach most likely is due to the timing of when we see these adverse effects.
Thank you. ¿Cómo puede influir
How can all this peer pressure, the social pressure coming from LGTB groups, how can this affect the development of scientific research? This trend that we see to indeed avoid psychological treatment or preventing the psychological treatment from happening, can that halt the progress of scientific research?
Question of how the whole scientific enterprise is being affected by this gender ideology is very, very concerning. And it's concerning beyond this issue of transgenderism. As scientists, we are trained to recognize bias. Recognize that when we look at objective scientific information, that we may look at the same information from different vantage points, but we have to be very critical. And we actually, the classic in a scientific experiment is you see a scatter of dots along a line, and you see one line hanging out in left field, and you say, well, that must be wrong, and I'm just going to ignore that data. That data, that point off the curve, may be the key to understanding what's going on. So we need to recognize when we're biased in our scientific pursuit and when we're influenced by the ideology and not using the scientific principles. Science doesn't answer everything, okay? We have to acknowledge science can only assess objective, quantifiable data that we can see, but it is very rigorous. And I think we heard earlier, that scientists as a whole are very skeptical. Our natural response in looking at anything is to question whether there's something true or false in that presumption, and we're constantly testing and retesting our hypotheses or ideas. If we accept the transgender agenda and we say that we've answered this question when we really have not, if we look at this in a completely biased manner and really are not willing to step back and ask alternative hypotheses, then the whole scientific enterprise falls apart. There are issues of scientific study. There are issues of academic freedom. There are issues that are critical in all areas of medicine that if we succumb to the pressures that are going on and do not pursue rigorous science, even ask the question. The concern is that among academic circles, when in any other area of medicine or science, we would be having this conversation. We would be talking about, is the hypothesis that this is due solely to social stress? Is the hypothesis that cross-sex hormones is the answer? We would be critically evaluating that question, examining the data as it emerges, designing new studies to pursue answers to those new questions that are evolved. And if we don't do that, science is dead.
En este sentido, ha respondido por adelantado algunas preguntas.
In this sense, you have answered in advance some of the questions, like, for instance, if you've ever met criticism based on rigorous scientific knowledge, criticism from colleagues regarding clinical guidelines. Questions like, for instance, like if doctors that see malpractice in this type of cases, should we report those colleagues that we consider are doing malpractice? Because we see the consequences that arise from this treatment. So is there hope to revert the therapeutical approach for these children? Well, there's many questions that we have received in that sense.
So the question is, how do we move forward in moving the dialogue?
Sí, como colectivos médicos, si por parte.
Yes. Are you finding amongst your medical colleagues critical standpoints to the approach that's currently being introduced under the pressure of LGBTI groups? If doctors who see how these treatments deviate, should we report on some colleagues who we consider are malpracticing?
Really a cover that's being present in the fact that these are within existing clinical care guidelines, that really the people that are providing this care will always turn to those guidelines and say, I'm following those guidelines, without critically evaluating them. And the role of all physicians is to do what's best in the interest of your patient and be able to provide that care. So it's going to be difficult to approach this because the harms that are being done are often not recognized, but the lack of information is recognized. I would say that in my conversations with my colleagues, more than half of them recognize the poor scientific information and have concerns about what is going on. Speaking to the area of the advocacy groups that are being able to push this forward, and again, recognize that the people that put these guidelines together were a fraction of the total population of physicians that are providing this care. A very, very select, small number with all, again, the attempts to broaden the pool of people engaging in this discussion did not happen to the extent that it should when these guidelines were developed. So to say that the guidelines are speaking for the entire community of providers is highly misleading. It's actually false. It's speaking to what we call experts in this area. And again, just like guidelines, the strength of the guidelines depends upon the quality of the evidence. The degree that one is an expert depends upon the experience that one has, and if one is not asking the proper scientific questions and designing the proper scientific studies, then they may have seen a lot of patients, but in seeing a lot of patients, that doesn't mean that they're getting any better. The analogy I like to draw, is to somebody that is practicing to be a basketball star, right? Mm-hmm. And if they're sitting there and if they shoot 1,000 basketballs a day in a dark gym, are they going to become a better basketball player? They're shooting in the dark. They don't know where they're going. They have no idea to know what the intervention they're doing, if it's having a positive benefit. So somebody that says they have experience because they've treated hundreds or thousands of patients when they're shooting at a basket in the dark does not make them any better as an expert. It makes them somebody who's practiced futility.
Mm-hmm. Ha comentado que hay algunos casos.
You mentioned that in some cases, in spite of having exceeded that point of pubertal of development in puberty, they still maintain that discrepancy between their biological sex. So, are there studies that have had findings
that mark the difference between those young people who maintain the gender misalignment in post-puberty and those who don't?
Of realignment of gender identity with sex before puberty and after puberty, and indeed there is evidence, okay? So that the majority of children before puberty, that's where we get the number of the large number of people that will realign their identity with their sex. The older they get, the further along into puberty, the rates will go down. It's certainly debatable as to what is being put forward about where the dividing line is. I would say that there is no dividing line. One can think about this in a number of ways, okay? So that if one is faced with a path, and actually it's not a single path, it's a path with many branch points, and the further one gets down that path, if they decide they're going to turn around and find their way back to their starting point, it's going to be much more challenging for them if they've had social affirmation, and certainly when they've had reinforcement with hormonal treatment, either pubertal blockade or cross-sex hormones, to be able, when they realize that this did not fix their problem, and then they say to themselves, what do I do now, okay? And it doesn't, so not speaking to whether this will, their actual identity will be able to realign at that point in time or not, whether they can do that, but the path itself is much more challenging. These are all open questions. So the answer to the question is that the older and further down the path that one gets, the harder it is for one to reverse courses. The reason for that is not fully understood. It's also not known, again, being multifactorial, are those that persist the longer if the causes that are present in that individual are the same or different for those that have this realignment earlier in their life. Again, a very important scientific question. It needs to be studied. It is not being studied currently, and we don't have the answer to that.
¿Existe algún tratamiento que...
Are there any treatments to revert sex change surgeries, even though I know you don't like talking about sex changes because, as you told us, sex cannot be changed. But this surgery that intends to change the external appearance of biological sex, once it's applying this type of surgery, is there a possibility to revert it?
About reversal of the external appearance that is modified, the cosmetic changes that occur. Again, as you mentioned very correctly, sex change is impossible. You cannot change one's sex. What you can do is change the appearance. And I am a pediatric endocrinologist, a hormone doctor. My specialty is in hormones, and I can speak much more to that. But I have conversed with a number of plastic surgeons, and there are certainly a growing need, a growing business for people that have gone through the surgery to change the appearance of their external genitalia, desiring to have the appearance return to what their biological sex is. That's actually a very growing concern, and more people are seeking that help. What surgery had been done influences whether that's possible. And what I'm aware of from my colleagues, the plastic surgeons that are involved in these reversal surgeries, there are widely varying outcomes, but I would say this would fit in the category of largely irreversible harm in many aspects of being able to achieve the function and appearance of the primary sexual organs that were present at the time of birth.
Y finalmente, muy brevemente para acabar, me preguntan...
And finally, to conclude, they're asking me about the training of young student doctors in medical schools about this topic that, as we see, is increasingly more frequent.
Yes, and we actually this relates to a bigger question of how students are being educated more broadly in the medical profession. And we've seen many dramatic changes in how people are trained. The paradigm that this is a vocation in medicine, that we devote our entire career and our life to our profession, is changing to cookbooks and shift work. Okay, so residents and young doctors are more likely these days to look at the guidelines as a cookbook and check the boxes and follow in without critically evaluating what is being done. A challenge that we have, particularly at my academic institution, is to maintain that academic vigor and to be able to continue to advance science and medicine by critically evaluating what is going on. I have major concerns about people, the young doctors, that are getting only one side of the story. What we have talked about this afternoon, I can say with a fair amount of confidence, is extremely rare for trainees to be presented with, because they've been people that even raise the questions about the treatment paradigm are often silenced. The people that are advocating, that are running these transgender clinics in children have a one-size-fits-all approach based upon the guidelines, and that's really all that the students are getting, and the students, not 100%, but the majority of them are not even questioning those guidelines.
De acuerdo. Pues muchísimas gracias.
Thank you very much. We hold high hopes in doctors like you so that you can make these treatments more visible, and we hope that there will be another way forward. Thanks to you and Dr. Cotella and doctors of your kind. Thank you.